Hi everybody, good afternoon. You've probably seen me a few times on previous Lunch and Learns. My name's Chloe Nicholson. I'm the Ageing Well Programme Lead in NHS Lincolnshire. I'll be supporting this session today, and we've been working with colleagues from across our system to hopefully produce a really helpful, practical update session for you. Without further ado, shall I bring Majella and Nicola in, Mark?
Yep, please do.
Yep, thank you. Majella, would you like to introduce yourself?
Yeah, hi, my name is Majella Wright, and I'm nurse consultant working for St Barnabas Hospice. I think I recognise some names on the screen already because about 5 years ago, in COVID times, I came and was available to answer some questions back in with Mark way back at the start of COVID. So I'm really pleased to be here today to talk about verification of death and generally about the after death care policy that's in place. Thank
Lovely.
you.
Thank you, Majella. If it's all right with you, Mark, I'd just like to bring in another colleague who's really critical to this conversation as well. Nicola Templeman, Superintendent from the Lincolnshire Police. Nick, are you there?
Yeah, so afternoon, everybody. I will have to switch my camera off because I am in an operational setting, and and people keep coming into my area where I'm working at the moment, as you can probably just tell by that. So I'm a superintendent. I'm in charge of our force control room, town inquiry office staff, and our enhanced video service that we provide. And I'm going to be talking to you today about when should you be calling the police for death-related matters in your care homes.
Lovely. Thank you, Nick. Thank you for your support in developing this update. So, are you happy for me to start the session now, Mark? Is that all right with you?
If you're right, I'll just do a quick overview. So this is the
Sorry,
seventh.
yeah.
This is the seventh lunch and learn, as in on various topics. I won't go through all previous six, and the whole previous six is that we've got experts in to talk on certain subjects, and a big thank you to Chloe for leading us on this way. And then at the end, after the presentations, there's then ample opportunity to do Q&As. We can do it two ways. We can do it by raising your hands using the little emojis at the top of your screen, or you can write something in chat. And I've got my wonderful assistant, Andrea, who works for Caring Links and Linker. And between me and Andrea, I'm sure we could be able to organise, we can manage the chat for you, Chloe. Is that all right?
That's wonderful, Mark. Absolutely, and I'll do the best at my end as well to support with that chat as well, and any other questions I might have received directly, Mark, if that's okay.
All right, over to you.
Lovely. Thank you very much. If you just bear with me, folks, we've just got a few slides to share today. But just before we do, I'd just like to just, I suppose, just explain. We were hoping to include a colleague from EMAS on today's session, East Midlands Ambulance Service. Although unfortunately they've had to give late apologies, so they won't be joining us today. And the reason for that, as many of you are probably experiencing yourselves, there are significant pressures across our health and care system, huge pressures in our hospitals and in our ambulance services. So I know that Andy was very keen to join this, and he certainly was intending to, but unfortunately he's not here today. He is happy to take any questions. So if there are any questions, Mark, that we're not able to answer, that experts on the call aren't able to answer today, I'll certainly take those back for Andy, and we can provide that further feedback. Okay. So just before we open this up, so today's session is about sharing a bit of an update on what the current position is around verification of an expected death. And this is within around the Care Home Lunch and Learn series. So this is meant to be helpful, practical. So please don't feel as though you're not able to ask questions. There are no silly questions. So please do do share your thoughts, any concerns, any questions that you have. And as I said, if Majella and Nick aren't able to answer those and you need advice from anybody else across the system, I will take those questions back and get a response back for you. So just a bit of by way of brief introduction, really. So obviously the session today is facilitated by myself and obviously Mark and the team in Lincoln, and the intention is to provide a bit of a better understanding on what to do and where to go when a person dies in a care home predominantly. Hopefully to bust some myths as well, and to provide some clarity on the roles and responsibilities around the verification of death. And hopefully through this process, it will support staff confidence if you feel able to and you're wanting to verify an expected death, and hopefully this will support you in doing so. As part of today's session, we'll be looking at principles of care after death, including the verification of death process, with reference to the Lincolnshire Care After Death policy. And I will put those links in the chat as well, Mark, as we're going through the session. We'll also be hearing from Nick, as she mentioned earlier, about what the difference might be between an expected and unexpected death and the role of the police in those circumstances. We'll be touching on the position from the ambulance service, and we have included a slide in the deck, although Andy is not able to be with us today, Mark. And we've also got some useful position update from the coroner's office following conversation with our local service earlier today. So just before we move into the first update, we'll be structuring today's session with an update from Majella, a little bit about the care after death policy and the role of care home staff. And also, like I said, we have a brief update from a slide that I'll refer to from EMAS, and then coming to Nick. And we'll also have plenty of time for questions and answers. So please don't feel concerned about raising any questions. Please do use the session as much as you can today. Okay, Majella, if you're happy to open up today's session, that would be great. Over to Majella.
Hi there, everybody. And as I've said, I'm nurse consultant here at St Barnabas Hospice, and we're a specialist palliative care service all across Lincolnshire. So that's just me and my slide, and we're going to go on to what topics we're going to explore today. So basically, we're going to be talking about an overview of the local policy and the legal responsibilities, the practical steps that verification takes. We're going to talk a little bit about communication with families. Then we're going to move on to cultural and religious considerations. And then it's really important that we consider emotional resilience for staff as well. So that's a really, really key point. So next slide, please, Chloe. I'm going to start today and talk about personalisation and a person-centred care. So we all know that when a person's care, it doesn't start or end at the point of death. The person that has been in front of you is a human being who's lived a life. That person has made connections and they've had important relationships. And it's important that we use their name and speak of them to enable us and others to remember them. The term care after death is used in place of last offices, and it's more befitting of our multicultural society, and it reflects the variety of tasks of care at the time of death, including supporting the family and those identified as being most important to the deceased. And often for you in care homes, you are part of that important people to the person that has died. So a little bit about the policy. The policy should be available in your local areas for all staff to have a look at. It's also available digitally on the End of Life website for Lincolnshire. And this is accessible to all healthcare professionals as well as members of the public. Why have we got this guidance? So it was written to support the after-death care of adults who die of an expected death in the community setting. And it outlines our responsibilities that need to come into action at that time. And part of this care is the verification of death. So you might ask yourself, what is an expected death? So this is when a person dies of a natural cause due to an illness that they are known to have had. The death is anticipated, it's expected and predicted. It might be the result of an acute or gradual deterioration in a patient's health, but it can also be due to advanced, progressive, incurable disease. It is anticipated in these circumstances that advanced care planning and respect discussions will have taken place and be recorded in the notes of that person. So what is verification of death? Basically, it's a confirmation or verification of death is deciding that the person is deceased, establishing that someone has died, or the fact that a death has occurred. What is important for the bereaved is timely and efficient verification of death. Adding there is no need to rush to do anything if somebody dies as well. Let's talk about the law. English law allows that any competent adult may verify that someone has died, but it does not place them under a legal obligation to do so. So who are these people? It could be care home staff, employee, a GP, a nurse, paramedic, a police officer, or even the person reporting the death, such as a family member. Some GPs may choose to attend for practical or support purposes, but there is no obligation for a GP to attend to do a verification of death. The British Medical Association and Lincolnshire Medical Council provided us with clarity in 2020 that in English law that there is no legal requirement for a registered professional to verify a death. The only legal requirement is for a registered medical practitioner, that is a hospital doctor or a general practitioner, to complete a medical certificate of cause of death only. So that is your medical certificate. Okay, Chloe, if we move on. So let's talk about the practical steps and verification of death. When a person dies an expected death in their own home without family or a key contact, it is vital that care companies understand the role that they play in place of the family or key contact. This is regardless of whether the care is funded by the NHS, social care, or privately. There is a responsibility to ensure that an appropriate individual confirms the death, to verify the death, if they feel competent to do so. As already established, that competent person will be a registered healthcare professional, an unregistered healthcare professional, or an unregistered social care professional. The CQC supports formal carers in care homes who have received training on how to complete the verification of expected death process and deliver care after death to the person and their family. These, who are usually senior carers, will also have access to supervision and support from the enhanced health in care home networks. The care home must have a robust governance procedure in place to support care after death, and this can include supporting the removal and storage of syringe drivers or catheters, etc. There is necessary paperwork to complete, and it includes who, if anyone is present at the actual time of death. The registered nurse or appropriately trained carer needs to record the time, who was present, the nature of the death, whether it was expected or not, and to record their own name and contact details in the nursing or care home documentation. And the official time of death is when the verification of the death takes place. That's a really important factor for learning today. So what is in the checklist around the process? So you're checking respect forms, you're checking any advanced care plans, any advanced directive statements, any notes around infectious disease, any implantable devices, for example, cardiac defibrillators, and hopefully all of this will have been covered in any that this will have been considered pre-death and pre-expected death, and that a cardiac defibrillator device would have been deactivated. A general principle is to adopt universal infection control precautions. Then some practical considerations. lie the person flat, and leave everything in place until a verification of death has taken place. That includes any catheters, syringe drivers. You keep them running until you have done the verification of death. I'm going to just talk very briefly about the process of assessment, and this is not making you going to be competent after this session. This is just a very, very brief introduction, because I think Chloe's going to talk about accessing training, etc. afterwards. The process of assessment is checking for cessation of the circulatory system, the carotid pulse, heart sounds, respiratory and cerebral function, and a trapezius squeeze. That's actually what the verification of death entails, the process. This should take at least 5 minutes of checking, and if interrupted, the verification process must start again from the very start. We also have to acknowledge that this can be very emotional for people that are involved, other residents that you may be coming in contact with, staff, and of course family and friends. And again, remember their name. You speak to them as if they're hearing you. Next slide, please, Chloe. So in communication, effective communication is more than just exchanging information. It's about understanding the emotion and intentions behind the information. Communication leading up to a death and care after death is an essential part of care delivery. Are we actively listening to people? Are we clear and concise in what we are saying? And what are our non-verbal behaviours communicating to the person that is there, that might be witnessing what you're doing? How does that come across to the individual and their loved ones in care after death? So a lot of this is pre-planning. It's very useful to know if any person has any specific spiritual care requirements to enable their needs to be met in their care after death. It is likely that family members have close connections to local places of worship and faith leaders if needed. Before death, does the bed need to be facing in a certain direction? Will there be a lot of people visiting? And is a vigil very important? Because in some cultures, it is highly important that there is a vigil, and that goes for many religions. And do we have a provision to accommodate these practices in our care homes? This is something for you to think about. Some spiritual groups have special requests that there is a calm and peaceful environment leading up to a person dying, and following that through for a few hours after death. In some belief systems, what people wear is very important. What they're going to be dressed in. Is that a shroud or a sacred garment, or simply covered in a white sheet? Do we know the answers to these questions? Have we asked them before death occurs? And how is this communicated to all staff? Again, things for you to think about. Some cultures have preferences over burials and cremations. And have we considered that? When considering some faith death, we do have to have certain considerations. Muslim and Jewish deaths have specific after-death considerations, and it is always useful to have an imam involved earlier on in the process to help navigate the particular preparations and routes for burials. For Jewish deaths, there are guidelines that need to be followed. And the Jewish community again have practices that need to be adhered to, and this includes contact with the body after somebody dies. Some cultures may have people from their local faith community attend and help wash and prepare the deceased. Some individuals may utilise the services of a death doula, a non-medical professional who makes themselves available to the key contacts for support before, during, and after a person's death. Some people want to spend time and sit, sing, or pray with their loved ones before they depart from their usual residence. We need to listen and make allowances and accommodations. And again, there are certain arrangements for people that die who are subjected to the Mental Health Act that wouldn't come under our criteria. Next slide, please, Chloe. I've worked in palliative care for over 30 years, and there are times when it's quite tough. I'm under no illusion that your work is any different, as you all build up meaningful relationships with the people you care for in life and in death. How do we sustain ourselves to keep working, to continue working every day at high levels? How do we stay emotionally resilient to give each person the care they deserve and what we would expect if we were in their position? And no way exhaustive few words are highlighted here. You need to have strong relationships to share how you are feeling honestly. Seek out those opportunities to share your thoughts. We need to be human and show emotion when situations are sad. It shows that we care. However, we have to exercise the right time to show this vulnerability. It mightn't be the most appropriate thing to break down and cry hysterically in front of a relative, and having them comfort you is probably not the right place to show that vulnerability. The most important thing is be kind to yourself and show compassion to others when you recognize that they may not be having a great day. Remember what is important to you and keep that in focus. And that finishes my slides. If you want to just go on, and that's what's important to me. And I'm happy to take any questions now, or we can go on to the next presentation. Chloe, over to you, back to you. Thank you.
Okay, thank you very much, Majella. Just before we move on, I think it's important just to kind of maybe just reflect a little bit on the great update that Majella provided there. Right at the beginning of Majella's slides, she mentioned the Lincolnshire Care After Death policy, of which I'll ensure that we circulate that policy, which is in the public domain, isn't it, Majella, to all of you on the call. We'll also ensure that we share with you the palliative and end-of-life website, the Lincolnshire Palliative Care website, which includes the link to the Care After Death policy, and also provides some really useful practical resources and support to care teams across the county. It's important to note that obviously today's session is not formal training, of course not. The Lunch and Learns offer support and direction, practical help and care. But hopefully the update provided by Majella there provides a little bit of context. We heard that the law tells us that registered and unregistered health and care colleagues are able to verify or confirm, if you like, that a person has passed, that a person has died. I suppose the question is, and if I was in your shoes, do you feel able to, would you want to verify a person's death? I think it's that point that we may want to think there is training available out there. There is training available, of course, via St Barnabas, isn't it, Majella? But also via various other independent training providers that will offer any further support, clinical support that you may be looking for around this. There is a really useful breakdown of the process around the verification of death within the policy that I'll share with you after this session. But just before I move on to the next slides, anything else from that, Majella, that you want to come in on? Sorry, putting you on the spot.
Yeah, no, I think there I probably should have started. We probably should have started the session by saying that just after picking up in the chat there that actually this is very sensitive to some people. So I'm glad that somebody did step away from the computer, and that is about, you know, you recognizing your own emotions, and that's really important when we are involved in care after death, because we have to care for each other and we have to recognize that we're all human beings and we all have feelings. So apologies that I didn't say that at the very start, that we are discussing a very sensitive topic.
Thank you, Majella. Yeah. Sorry, Andrea, did you want to come in just before we move on?
Just because there's a comment in the chat. So Lindsay in the chat has put, in our home, we have to call CAS when there is an expected death, and the clinician calls back and helps to verify death, do we still need to do this, or can we go ahead and verify ourselves?
Majella, are you happy to come in on this one?
Yeah, from my perspective, it depends on if a person feels competent to do so. That's really, really important, that you have a good governance structure behind you, that you have the support available in your organisation to answer any questions that you might have. Is it my understanding that Kaz speak to you over the telephone about taking you through these steps, Lindsay? Is that correct? Yes, that's right. Okay, this is very interactive, the way it's working. It depends on the confidence of the people that are making the phone call, and if they feel competent to do the verification, if it's okay with the governance of your employer, then I guess that is okay.
Okay.
A lot of people seem to be doing that, so it maybe actually our colleague paramedic that was supposed to be here might have been able to answer that question a little bit more succinctly, but maybe Chloe could come back and provide further information to detail that after the session.
Absolutely. Yeah, thank you, Majella. I'm more than happy to take that back. Thanks, Andrea, for your help. So I can't see what's going on in the chat as well. So my offer to support is fairly redundant. Sorry, because I can only see the screens.
I just wanted to add, Chloe, I think you're going to, I mean, Majella, you did brilliantly, thank you. And I'm sure, Chloe, you're going to continue. But I think for a lot of the homes, when you say it's confirmation rather than verify, I think sometimes that really helps. Do you know what I mean? Just that wording. Yeah.
Yeah, and I think because for quite a few years we've actually been saying what a verification. That's why the word verification is used a lot. It's on top of all the forms that we use within Lincolnshire, probably nationwide. A lot of people speak about verification, but it is used it could be used interchangeably with confirmation, because really all you are doing, my whole talk was actually, you are just saying that somebody has died. That's what you are doing when you are doing a verification of death. You are just confirming that a person has died.
Great, thanks, Majella. Andrea, I'll continue through the slides unless there's anybody else that wishes to come in. Please do stop me if that's all right. I'll look to you, Andrea.
Sorry, Chloe, there is something else. Somebody, Nicola has put, we as a care home used to verify expected deaths. However, our GP surgery were not happy with us doing it, so we went back to calling the palliative team to verify over the phone. So it's just interesting that there's a few little things coming up there.
And I guess the answer to that, a lot of GP surgeries will be quite protective over their processes as well. So you've just got to work with what works in each area. There's not going to be a blanket way of doing this across every place, because there will be different processes. Sometimes GPs actually like to come out and see people even though they don't have to, or that they like somebody from the GP surgery to come out and see somebody, especially if they may have not been involved in their care as well in the last few weeks or months of their life.
Thanks, Majella. Just to add to that, I think part of the reason why we wanted to connect with you today and bring our experts in to connect with you is because of the variation in different approaches, not just across our county, but across the country as well. Wouldn't you agree, Majella? Because whilst we know what the law tells us and what we're allowed to do, like Majella says, each area may have a different approach. Some areas will not send a GP out, therefore there may be a different approach, but other areas do. but two people on the call there, Andrea, have mentioned the support that CAS provide and the palliative team provide. So there is support out there, and of course through the EHCH colleagues as well, who may well provide that clinical support and advice to care homes, and we're hearing that already. Is it anything else that we want to come in on, Andrea? Otherwise, I'll carry on.
Oh, that was the last comment there.
Thanks, Andrea. That's great. And again, we'll keep stopping incrementally, and so please do shout out. Okay, thanks, Majella. Majella isn't going anywhere, people. So just to let you know that she is staying here. If you think of any more questions, please do let us know. Just before we move on, I just wanted to share with you this slide here, a really useful conversation with Mr. David Stocking, who is our Coroner's Office Supervisor in the Lincolnshire Coroner's Service. And interestingly, David also mentions here about confirming death. The word verification can sometimes be a bit confusing, and he said, actually, realistically, it is about confirming death. So why do we need to verify death or confirm? Essentially, it starts the process. It starts the process where the coroner and other colleagues will and GPs and other medical colleagues to certify death. So they need confirmation that the person has passed before a certification can be provided. Of course, there are health and safety implications, and we certainly saw this through the COVID period, didn't we, Majella, around transfer of any infection, etc. Majella's touched on a lot of this, but I just wanted to connect you in with Mr. Stocking here, because he wanted to reach out and offer any support that you may need. He also mentioned that it's really important that verification is timely, to support with the bereaved families as well, and to ensure that there's no undue delay in managing the certification and minimising the challenges that families and carers might have when that person passes. So in summary, just to reiterate what Majella's mentioned there, Mr. Stocking says it doesn't need to be a medic. We know that. We know that it can be care staff, or it could very well be a local health and care team who are there already supporting the person before they passed. He said if care staff feel comfortable confirming death, he knows that is in place a lot. This is being implemented a lot across the county. David wanted me to pass on to you all, and I'll share these slides with you, his contact details. He said he's very happy if there are any specific concerns around the involvement of the coroner or the coroner's role or any particular cases that you're querying. Please don't hesitate to contact him or his office, and he'd be happy to support. So I just thought that it was important to just ensure, whilst David can't be here today, he's very much around if people do need that support, and he did reiterate that this morning on a conversation I had with him. So I'll share these details after the session as well, just so that you have those. Okay. I'll continue unless I hear otherwise, Andrea. Okay. Again, we've apologies, folks. We have received apologies from our from Andrew Lister, our EMAS colleagues, but I thought it was just useful to include this slide. When should care home staff call 999? So, in a nutshell, if the death of this person was expected, perhaps due to terminal illness, as Majella mentioned earlier, there is no need to call 999. You should contact the deceased person's appropriate healthcare team, which many of you are doing already, and have that conversation. And maybe if you feel happy to, you may want to confirm the death with the healthcare team at the time. That will then enable the certification of death to follow that. If, however, the death of that person is unexpected, then that is where a 999 call should be made. And at that point, I'm just going to introduce our next speaker, who will just mention here a little bit more about the role of the police within the verification of death. Okay, Nick.
Afternoon, thanks, Chloe. So I'll firstly kind of put a few little caveats around the next few slides, because I am not a trainer, and these slides are very much more practical and quite detached and less personal to the slides that you've had already, and that's for obvious reasons in terms of the policing involvement is often on that kind of more practical level. So I apologise for that, because I do refer to people as deceased, etc. in the slides. So apologies if that is upsetting to anybody. Next slide then, please, Chloe.
Thank you.
So I've been asked to come today and kind of try and provide a bit more clarity for people around when should the police attend, when should we be involved. And for most people on the call, you all know that most deaths, unfortunately, in care homes, you know, they do happen a lot for you guys, but they will not require the involvement of the police in most of those occasions. And that's because the death is either expected or likely to be expected. It's due to natural causes. And in most cases, it's not a surprise. So it may be a surprise to family members, perhaps, whether it's happened quicker than they expected, but it's probably not a surprise to those medical professionals who have the kind of the fuller picture and the less kind of personal impact. And often there is nothing unusual, unexplained, and there's no suspicious element in the death, and therefore the police are not called. Next slide, please, Chloe. Now, on the flip side to that, again, just in the care home kind of context, when should the police be involved? When you have either evidence or suspicions of some criminality, so that could be neglect or abuse or an assault. Could be concerns around environmental hazards. So, you know, if there is perhaps a gas leak or a suspected poisoning, whether intentional or not. Unexplained deaths where perhaps multiple residents perhaps die suddenly, and there's no clear medical cause for that. We often get kind of referrals into the police from either the coroner, who may have come across a case that they just want that extra investigation into. Sometimes we get calls from GPs, paramedics, and also from care home providers themselves, sometimes asking us to have a look into the circumstances. And then on some occasions, we get calls where a person perhaps who has very limited mobility is then found deceased at the bottom of some stairs. Again, that would be unexplained as to how that's come about. Just one thing I wanted to reference here is that in most of these cases, the police will be involved as part of a multi-agency response. It won't just be the police acting alone. We will require cooperation and support from partners as well to establish the cause of death. And next slide, please, Chloe. So if a death is believed to be suspicious, this is when one of the questions I was asked to bring was, what would we do with the scene? People are always quite nervous that they might lock down scenes too much or too little, or that they're going to have all their clothing seized, and you know, they don't want to get things wrong and jeopardize anything. So what I would say from our perspective is, it's easier for us to scale back a scene rather than try and turn back the time and capture things that are lost. So if you believe that something is suspicious or there's something not quite right that you believe the police and others should be involved in to look at, then if you lock down that scene and kind of do these next couple of actions, it won't do you any harm, and we can always lift a scene rather than try and put it on 24 hours later. So the thing for us is, when you come across a death, you're still going to have to confirm that death clearly. So, and on some occasions, there may be also a requirement to try and preserve life. So they are always going to take priority. So protecting life is always the priority for every agency and person. And then once you've either exhausted that or taken necessary steps, then that's when we would ask for a focus on preventing contamination or loss of evidence. So going to the points one, so confirm death, and number two, preserve life. So there could be occasions when you have to move people around, you know, and if you have to do that, then there's your justification in order to preserve life of others. If you can or need to, you can treat the room as a crime scene, so restrict access, close the room, restrict who can go into that room. You can keep a written log of names, roles, people that may have to go in and out, because there may be other people that perhaps are in that room that you do need to attend to. So if that happens, then just log what the requirement was and who went in and out. Next slide, please, Chloe. Number 5 is preserving the body and the surroundings. So there's just some guidance there. I've put quite a lot on these slides so that you can refer to them in your own time, because sometimes it's easier to read things rather than just listen to somebody talking. So there's some guidance there around not removing medical devices. So this is all, again, in the context of believing something not to be quite right, something suspicious, something untoward. So this is not obviously in your normal circumstances. Again, preserving medical equipment, medication, charts, food, drink, supplements, all of those things. So now, again, at the bottom, there's a caveat that if something must be moved for safety reasons, then please do that, but just document what, why, and who, and when things were moved, so that that could be taken into consideration by our crime scene experts. Next slide, please, Chloe. Again, number 7 on this is around securing documentation. So there's always elements of care plans and risk assessments and incident reports, rotas, next of kin details. All of these things are useful that if they're made available at the earliest opportunity and are kept up to date. Next slide, please, Chloe. So the next question I was asked really was about what can care home staff make sure they've got kind of in preparation for if this was to ever happen. So I suppose it's about us all working together. So a suspected suspicious death in a care home will require lots of other agencies to be coordinated. We need to be clear on what each other's roles are, and we need to make sure we have disciplined communication, because it's a worrying time for lots of people. I do have to say, when the police get involved, we don't always make things easy for people, because just our actual attendance can often cause worry and upset. There's likely to be a multi-agency response, so the care home providers, the coroner, GP services, other NHS, local authority safeguarding and regulators, so it can be quite a disruptive time for everybody. It's useful if the care home provider single point of contact, likely to be a senior manager, who can then coordinate either access to records and make sure that staff are communicated, but with the same message, because communication, as we know, is something that normally is the thing that fails, that is what people get disappointed or upset because they either are given miscommunication or no communication, and that's including the police in terms of what we communicate as well. So those elements can avoid all of that, either missed evidence or repeated requests or delay. Next slide, please, Chloe. And also just then moving on, so early stages, we're quite needy in the police. If we attend, we are going to need lots of things, and it probably quite a quick turnaround. So there's that extra pressure that we put on yourselves. So we are likely to need things like the time and circumstances of death, who found the deceased person, what actions have been taken, are there any risks or other incidents of note that you want to make us aware of. We will often want to come and examine the scene. That we can take time on that sometimes, unfortunately, depending on what else is going on across the county in terms of our CS, our crime scene investigative resourcing. It would be useful if the SPOC, the single point of contact, has details of who was on duty, making sure that those staff can be available, so that prompt access can avoid extended investigations, because we know that police investigations can take time, and that time builds uncertainty for everybody. We need to work together to make sure there's clear communication with families. And then our other advice would be the contact with either police, other agencies and families, that there's a timeline kept as to who was contacted, when, what was agreed, and any actions or constraints or decisions. And that protects care home staff, the residents, and the integrity of the investigation. Next slide, please, Chloe. Oh, that's it. I forgot. That's my last one. Apologies. I was on a roll.
Yeah, thank you so much, Nick. Just before we kind of come to the end of our formal slides, can I just ask Andrea, are there any questions specifically for Nick in regard to the police?
No one's put anything in yet, but if anyone's got questions, do please either put your hand up or put them in the chat.
Thank you, Andrea. So that brings us to an end of the formal slides for today's session. I think it's useful just to note, of course, we felt that it was important, obviously, as one of our key partners, Nick, in the police, it's important to discuss cases where the police may be involved. However, we do recognise, of course, that touch wood, the majority of deaths in the care home, of course, may well be expected, and it may well be that the update from Majella and the care after death policy will hopefully provide some useful support to you and obviously those health and care professionals that are already providing support into the homes. But we thought it's certainly useful. Hopefully that's been helpful to you to have those updates from the police as well. What you'll see on the screen here are the links to the Lincolnshire Palliative and End of Life website and also the link within that website to the care after death policy, which, as Majella mentioned there, it does include the verification of death process within that. And I will, once I've come off these slides, Mark, I will look to add those links into the chat as well. So I'll finish the slides there and happy to open up to any questions, Mark. Thank you.
Okay, so anyone got any burning questions you want to ask sort of the panel we've presented plus Chloe? If so, if you stick your hand up or go into chat, we have got plenty of time to do that. There's no pressure at all. So my question is to you as providers. Are you struggling to find expected verification of death training? Or you feel that you are covered by what the marketplace is offering? So that is something I'm asking you as care providers. Also, we've got some home care providers on here, and I think in Majella's presentation, there was a couple of slides, and I think it was the third slide itself was about dealing with someone in their own home and how to notify. And I think that's something which we could look at down the track for home care providers. Has anyone? Thank you, Sarah.
Right.
Thank you, Denise. If you've got suppliers who are delivering that training, if you drop me and Andrea who they are, we can actually potentially share them with other providers so that they've come, we're already in the system. And if you're giving sort of a testimonial so that they're good, then we can share them. I go back to the offer. I know Majella's already offered from St Barnabas. I think there's elements of discussion with St Barnabas around that. And I know some of their training they offer is superb from first hand, but there's also the opportunity to work with our system partners even closer still. Kaylee Moss, my understanding is the answer is yes. I think Majella is nodding away. Yes. Thank you, Tony. Yeah, medics do the training, verification of expected death. Okay. Chloe, it seems there's no hands up. There seems, is there any for summaries you want to sum up?
I think really it's about raising awareness of what's already within that policy that we've shared there, and I think it's about saying we know that care home staff and care staff do have a key role to play in the confirmation of death if they choose to, and if they feel confident and competent within that. There is support, as people are already accessing, through the clinical advice service, through CAS for care homes, through the community palliative care team. So there is, and of course the PCN enhanced health and care teams, which people are already connecting in with. So you're not on your own within that, but hopefully Nick and Majella and others have hopefully highlighted the current position. There is variation. And it may be that in some areas, like Majella mentioned, GPs do want to continue to verify death. So it's about working with your system partners within your locality, within your neighbourhood, working out how people, what support there is, and how you'd like to proceed with that. There is support available, as we've mentioned there, and there is a training offer provided. St Barnabas, just one of those independent providers as well. So I think we've got lots of offer of support out there. If there are any questions, Mark, more than happy to take those. As people, I'll put our Aging Well email address in the chat. So please don't hesitate to reach out, and we'll aim to get the answers for you. Okay, thank you, Mark.
Okay, thank you. Just do a bit of blind advertising. The 4th luncheon, the 8th Lunch and Learn, it'll be in about a month's time. Is that right, Chloe? Are we going for a month's time?
Yes. I'm sorry. Yeah, I'm blindsided me there. I
Yeah.
can't remember the particular. I can't remember the date. Yeah. But we'll. Yes, I better.
Hold on, I will
check the date and come back.
I'll tell you the dates actually, because I'm just opening it up. 18th of February.
Right, that's right.
And we are talking about deconditioning and prevention of pressure ulcers.
Yes, that's right. Thank you, Mark.
Thank you.
Yeah. You're right. I do look a bit vague. It's only because I have my head into verification of death. That's right. So we have our team from local community services who will be providing that update to you, and we'll get a summary. If I haven't already sent it to you, Mark, that will be out to you imminently, around a little bit of detail about that. That may have already gone out, has it, Mark? Sorry.
No, we will be sending it out early next week. The slide packs from today will be available, and we'll be sending out to those people who have logged in today, and for those homes who have logged in from one of those care providers they are logged in from as well. So they will be going out later on today. Big thank you to both our speakers, to you, Chloe, to Andrea, helping us onto the into the chat as well. And Andrea.
Sorry, I didn't know if you'd seen in the chat, someone was asking if there are going to be any face-to-face lunch and learns.
There would, but there would means that people would have to pay for them, because we would have to pay for a venue. So virtual works for most people, and we do a lot of virtual catch-ups. So at the present moment, the answer is no. Okay, big thank you again to all of you giving your time up, and we'll see you next time. Bye bye, folks.
Thanks, Mark. Thank you all.